Thank you for tuning in to Team 14. We are Team Bay, looking at the best antibiotics empirically. Multi-drug resistant organisms are a major problem in healthcare and accounts for 1,700 deaths a year in the US alone. And selecting the right antibiotics is not as easy as it sounds. Imagine this: Mr. X, 56-year-old with poorly controlled diabetes and recent ICU admission 3 months ago, now has community-acquired pneumonia a week ago and treated with He came down to your ICU and you diagnosed him with most likely septic shock. You took 2 sets of blood culture, and like any other good doctor, you want to start the patient on a broad spectrum antibiotics within the first hour of him coming down to ICU. But what is the bug that we need to treat? We know that a typical culture will take about 2 to 5 days to come back with the sensitivity, and we see that in our own mimic dataset. Meanwhile, the clock is ticking. We are now at a clinical decision point. Should I escalate the antibiotics? And if yes, to what? Well, we are not totally clueless. The hospital antibiogram does serve to help us with antibiotic stewardship. Despite this, 30 to 50% of antibiotics prescribed in hospitals are unnecessary or inappropriate, and it is not an individualized treatment. So, what if we just give everybody the strongest antibiotics possible in the first place? Well, that is the cause of the problem. And currently, some of the most common MDROs that we have includes VRE, MRSA, KPC, ESBL, just to name a few. So we want to create a model that predicts which patient will have MDRO on admission to ICU and hence may need a stronger broad spectrum antibiotics. And we want to make sure that it is easily implemented and interpretable. We decided to look at the MIMIC4 dataset as it gives us information about the preoperative data such as recent antibiotics, cultures, lines, and ICU admissions, such that when Mr. X comes down to us, we already know pretty much a lot about him. We excluded children and those patients with previous MDRO infections. We looked at patients with positive cultures within 3 days from the ICU admission and extracted data such as demographics, past medical history, current hospital admissions, together with the antibiotics that was given and the cultures. We divided the cohort into 2 groups, and the control group are those that grew positive cultures that were sensitive. We have about 1,500 patients in the MDRO group and about 3,500 patients in the control group. This is the demographics, and we can see that patients with MDRO are more likely to have received medications such as antibiotics and immunosuppressants and have comorbidities such as weight loss, liver and renal diseases, hypertension, diabetes, as well as COPD and anemia. We then run these features through machine learning models, and using a fully connected neural network for training, we ask, what is the risk of Mr. X having MDRO infections? We then did various machine learning models and found that the best predictive model is that of the extra trace classifier. For reproducibility, all the codes used for feature extraction and model outputs are saved in GitHub. For some of the insights to our machine learning model, we can see that the most important predictor factors are that of immunosuppressants, liver disease, weight loss, surgery, and renal failure. And the AUC that we got was 0.77. Now let's go back to Mr. X. You are in the ICU again, seeing the same patient with the same comorbidity. With predictive modeling, we're able to tell what is the likelihood of Mr. X having MDRO infections and therefore help us with our antibiotic stewardship. Some of the future work that we are looking at includes further subgroup analysis based on the source of sepsis as well as the specific MDROs. And we want to integrate this into existing hospital platforms to aid clinical decisions. And with that, we would like to say thank you very much.